people can ask questions through audio, and we can address things that way. So I'll give you a little bit about myself. I am, like I said, I'm currently a nurse practitioner. My nursing career started here in Winnipeg. I did the 2-year RN program to start. Worked a little bit in rural Manitoba, where I also grew up. I then got a bit of a travel bug and ended up working overseas in the United Arab Emirates for 3 years. Thoroughly enjoyed that. Spent some time also with the Tanzanian Red Cross in Africa. Ended up, I always come back to Winnipeg. Every winter, I wonder why, but I do come back. So I came back to Winnipeg. While I was overseas, I finished my BN through an online program. So I understand how this online stuff works, both from student and instructor's point of view. I enjoyed nursing. I wanted to get further into it. So working in the emergency department here in Winnipeg, I decided to go back to school again, and I took the nurse practitioner program. So in my nursing career, I've done everything from recovery room, nurse anesthetist, ICU, emergency, some rural nursing, and then as a nurse practitioner, my focus is primary northern and some rural, as well as primary care. So that's a little bit about who I am. I currently, as a director of the nurse practitioner program, work obviously with the nurse practitioner program, but my focus again is primary care and women's and pediatric health, as well as health assessment. So that's going to be our focus today. So in a 1-hour time frame, we can barely skim the surface when it comes to health assessment. Normally it's a large course, but we're going to kind of talk about some of the fundamentals, some of the things you need to know in order to go forward, and you can do some of the studying and that kind of thing on your own. I've provided some tools for you to be able to take as a checklist if you're wanting to practice on your own or work through a health assessment. Along with, if you're using a textbook, you'll be able to work through that on your own after this as well. So I'm not seeing any questions so far. I see some webinar questions, etc., but I think we'll move on and start with the PowerPoint. Just give us a moment and we'll pull up. All right, there we go. So you'll see me off to the side, and then we'll have the PowerPoint. So these PowerPoints are very simple. They're just a little bit of a guideline as to things that we're going to be going through and talking about. So on the first slide, we'll go to, so learning outcomes. So again, this is more of an introduction foundations of health assessment. So identifying the elements of a physical health assessment. So what do we do in the physical health exam? Why are we doing it? Things we need to consider. There are different types of health assessment that we'll talk about, and then we'll introduce you to using the checklist, how our lovely assistants here will help us kind of work through to be able to apply some of the concepts. So next slide. So as an overview, there's things that we need to do in preparation for going in and doing physical exams. So what do we need to do? What do we need to have considerations for? We can't be walking in thinking that we can treat every patient the same. So the different patients are going to have different considerations when we come to these kinds of things. We're going to talk about the fundamentals, and then we're going to just discuss IPPA, and that's an acronym that we'll get into. Had to throw in a little bit of humor because otherwise you're just hearing me talk, and how exciting is that? So we can use our tools, but if we're not using them appropriately, checking the blood pressure in this poor man's neck, we may not be getting the outcomes that we want. So next slide. So in preparation, so we're starting off with environment. When we're going in, we're going to do a physical exam, so things to consider. So what is the temperature of the room? Is depending on what kind of physical exam we're going to be doing, whether we're in hospital, we're in a clinic, in outpatient, in emergency, what is the environment like? So let's say we're doing the physical exam on an infant. it's important to be keeping them warm. They're going to be losing a lot of body heat. A patient that's in hospital, do we have blankets around, those kinds of things, to be able to keep their temperature and keep them comfortable. Privacy as well. So that's a tricky one sometimes in hospital situations. So pulling the curtain as you can. We're asking private, intimate questions often of patients for history and physical exam. And curtains don't really work as a great sound barrier, but providing that privacy as you can, using blankets and drapes to keep the patient comfortable, not exposing more than what we're needing to. What is the noise like? If you're asking patients questions, you're asking them to do things, you're trying to auscultate or listen to a chest, and there's a lot of noise, there's a lot of stuff going around, it can be distracting both for you and for the patient. Some of that's going to be out of your control, but it's also something to consider when you're working through a physical exam. And lighting. So that's going to impact for what you're going to be able to see. So if I'm trying to examine, let's say, somebody's skin, looking for rashes, etc., if I've got really poor lighting, I'm probably going to miss things. It's much harder to be able to see what we're doing. Equipment. So we all like tools, etc. We've got our stethoscopes. We've got our, what are my other tools? I'm hiding here. If we're checking reflexes, we need our hammers. Our tuning forks, etc., your blood pressure machine, whatever you're going to be doing. So knowing ahead of time what your physical exam is going to be requiring in terms of equipment, so that you're not getting to the bedside, you've set up environment, and then you get halfway through your exam, your patient is now exposed, and you realize you've forgotten something. The next thing is positioning and draping. So I talked a little bit about having privacy, keeping the patient covered to provide some privacy for them. How are we positioning them? So if I have a patient, let's say, that has back issues, and I'm requiring them to lie flat on their back so that I can examine their stomach, and it's very uncomfortable for them, or they're in pain when I'm doing it, I need to consider, how can I make this more comfortable for them? How can I also make it more comfortable for myself? A lot of the times the patients are in beds or on exam tables or in chairs. If we're doing this all day, trying to look in ears or listen to chests, we're setting ourselves up also for back injuries or those kinds of things. So it's being in positions that both you and the patient can be able to be comfortable, as well as being able to achieve what you need to achieve. If we're working, where did I put mine? Need my otoscope, sorry. All right. If I'm working and I'm wanting to look into somebody's ear, if they're positioned at the perfect height for me to be able to look in their ear, then fantastic. Most of the time it's not. If they're sitting in a chair, I'm trying to get down in there and doing this. Or with a kid, we're working with whatever shape and struggle that they're in. So planning ahead a little bit as to how we can position and do things so that it's both, again, comfortable for the patient as well as for ourselves. So I mentioned there's the different types of physical exam. So we can have a comprehensive or a focus. So comprehensive would be that checklist that I've provided that goes from your head to your toe, doing a full assessment of everything from skin to a neural assessment to MSK, etc. So that's when I'm looking at all of the systems of a patient. We don't often do that. It's important to know how to do that, important to have a flow when you're doing it. But it's not done as frequently as if we're doing a focused assessment. So again, let's say I'm working in a GI unit on the hospital floor. So most of my patients are post-op, having had some sort of gastrointestinal surgery. That is going to be more of my focus when I go in to see my patients. I'm going to be considering everything that is going to impact that. So I'm probably going to be looking at hydration, looking at skin, are they perfusing well, those kinds of things around being post-operative, as well as anything to do with that system. So are they eating, drinking, are they vomiting, do they look comfortable, is all going to be a bit of a general survey. Then I'm going to get down to if they're having any pain, what does the incision site look like, what does their abdomen look like, doing an abdominal assessment. So in that scenario, I'm not doing a full neuro, I'm not looking in their eyes, I'm not checking reflex, because that's not really relevant. I'm focusing on what's relevant at that time. Being systematic and organized is very important. If you get into a flow where every single time you're doing the same thing, so we'll talk about IPPA when you're doing inspection, percussion, palpation, and auscultation. You can do that same format all the time, and a physical exam will start to become second hat. So with that, there's different ways of approaching it. If you're doing a full head-to-toe assessment, so the skin, so dermatology can either be something that you do a full survey and look at all of this skin first and then work through the systems, or it may be something that I'm going to look at the skin when I do the head, I'm going to look at the skin of the face and scalp. When I assess the arm and I'm doing range of motion and neurological exam of the arm, I'll assess the skin of the arm at that time. So you can compartmentalize your assessment in different ways. It's not wrong to do it differently. You need to find a system that works for you, and kind of how does your brain work to be able to remember those things. There's special considerations for that. So I'm going to go to the second point with pediatrics. When you're doing a pediatric exam, you may have a system in your head where you're going like head to toe with an adult, and you come to pediatrics and you're going to throw that out the window. A kid is not going to sit there for you. Let's say you're working with a 2-year-old, for you to have a 30-minute exam of their head to toe. You're going to have to work with whatever stage they're at and whatever they're going to allow you to work with. With pediatrics, we usually go from least invasive to most invasive. With infants, again, you want to be checking things when they're quiet. So I may jump right to listening to the heart and lungs of an infant when they're sleeping and happy in mommy's arms before I go and look in the ears and make them start crying. So you're going to have a couple of special considerations there, especially with pediatrics. With elderly, there's different considerations in terms of elderly, and it can touch on a number of different things. So it may be mobility. It may be having multiple complaints or multiple issues going on at one time. Let's go back, let's say, to the GI post-op patient. So we're in hospital. We may have a patient that is elderly that's had, say, a hernia repair. I'm going to be concerned about that hernia repair, but they may have other chronic diseases, some mobility issues that are going to change a little bit of what I do with them compared to what I would do with the same individual having had a hernia repair at age 26. I'm going to have other considerations if they're diabetic, if they're wheelchair bound, if they have let's say severe osteoporosis and aren't able to lie flat on their back, those kinds of things. So knowing the whole patient will help you with those special considerations. So individuals with impaired mobility, when we're doing a physical exam, we're moving around, but we're also making our patients move around. So we'll have them sitting, we may have them standing, we may have them lying, we may have them walking, depending on what we're assessing. So considering how can the patient move? How are they comfortable? What are they able to do? Let's say a woman that's 9 months pregnant, for her to be lying down flat isn't recommended, be uncomfortable for her, those kinds of things. She won't be able to tolerate it long, neither with the baby. So you're going to consider that her mobility is going to be a little bit more challenging. There's certain things she's not going to be able to do. So it doesn't only apply to somebody, let's say, that has an obvious wheelchair or cane or is elderly. There's considerations for impaired mobility across the lifespan. Individuals with intellectual disabilities, it's important to consider the fact that we are coming in to do a physical exam, which is a very intimate thing for the patient. It can be a very scary thing if they're not understanding what's going on. So taking the time to explain what you're about to do, making sure they understand and are able to give consent if we're doing anything that's invasive or exposing areas of them that they may feel uncomfortable with. You want to make sure that they are on board with it and they're not feeling violated through the process. With that, if a patient does have a history of abuse, you may or may not know about it. It's important to consider when you're doing a physical exam. So watching where you're putting your hands, watching how you're placing your hands, those kinds of things. If you have a woman, let's say, that is a larger woman, and we're needing to move her breasts out of the way to be able to listen to heart sounds. around the chest region. I'm going to use the back of my hand to move tissue and place the stethoscope. I'm not going to use the palm of my hand. So you're always using the back of your hand when you're moving tissue. It's less invasive and less uncomfortable for the patient. Also consider the fact that vulnerable populations or people that have had a history of, let's say, something that has been abusive or has been placed in a vulnerable situation, these things may make them uncomfortable and may make them come across as being less compliant or less cooperative. And it may not be the fact that they aren't willing to be assessed. It is more so the fear or the unknowing of what's going to be happening. So taking the time to discuss it with them and taking your time as you're going through the assessment and reading your patient as to how comfortable they are and how they're responding to what you're doing. Language is another key. So are we using terminology, not only medical or layman's terminology that our clients or patients are going to understand, but also do we speak the same language in terms of English, etc. So we can use English term for something that one person understands, another person may not. Are we using appropriate language? There is an importance to use layman's terms, but if we become too slang as well, there's opportunity to be crossing lines. So that's a bit of a tricky one sometimes. You want to express what you're doing, you want to explain to the patient what you're about to do in layman's terms so they understand, but being respectful of language and ensuring that there is an understanding on both parties. So I'm going to talk a little bit more and then we're going to glance back and see if there's any questions that have come up. So the most fundamental key thing after you've set up everything else that I've talked about is understanding anatomy and physiology. So that's why I brought my wonderful friends here with me. Everything we do with physical assessment is to do with underlying anatomy and physiology. I can go and listen to the heart sounds, but in the back of my head, I need to remember and understand where exactly do the lung bases and where do they start. So I'm going to remove the field here on the one. So if you look at the top of our clavicle, the lung base goes all the way from the top to the bottom. So sometimes when we're doing listening to chest sounds, etc., we'll start lower down in the chest, forgetting the fact that our lung fields go way up top here. So if we're listening to the full lung field, we're starting right from the top and going all the way to the bottom. So again, remembering what our anatomy and physiology is underneath. If I'm, let's say, palpating for the liver, I need to understand where is the normal liver situated, and if I'm palpating, is it normal to feel a liver, is it abnormal? We can go through the motions of doing a physical exam. I can place my stethoscope in the right places, but if I'm not understanding what's going on underneath, what I hear isn't going to impact me. So I need to understand the physical anatomy of the patient so that I can correlate that to what I'm doing. We'll go into a little bit more about that as well as we go along. So understanding the purpose of the assessment. Am I doing, let's say, an assessment for a driver's form? Am I doing an assessment for a student to be able to be fit to participate in a physical activity? Am I doing a post-op assessment? Am I doing a pre-op assessment? What is the purpose of it? That will guide what we're looking for and what we're doing. So if it's a post-op patient, I'm going to be considering possibilities of signs of blood loss, signs of shock, signs of infection, which are going to be different things that I'd be looking for in, let's say, a grade 5 student coming in with a form to be able to participate in soccer. So having that understanding of what is the purpose of our assessment and knowing those abnormal findings. So one of the examples that I like is when the FBI are trying to be able to determine if something is counterfeit, they study and study and study the real thing. So then that way, as soon as they see something that's abnormal, they know it's a counterfeit. So I say, listen to every heart sounds that you can in person. Listen to everybody's chest when you can. you may not be able to determine, oh, this is, you know, a grade 2 murmur, and be able to identify the exact type, but you'll be able to listen and go, you know what, this is not normal. This is not the heart sounds that I've heard all along. So just studying and being able to determine what those normals are the absolute first step in being able to determine what's abnormal. And then being able to describe what is normal, what is abnormal. Describing lung sounds. So, you know, chest is clear with good air entry throughout to the bases. You know, not hearing wheezes. What does a wheeze sound like? What does crackle sound like? Whereas my 4-year-old daughter calls them as weasels. So you want to know what you're looking for, want to know what you're assessing for, and then being able to describe the abnormals and abnormals within context, be able to report and chart on them. And practice makes perfect. Like I said, starting out, I listened to every heart sounds that I could. As a nurse practitioner, as a student, I looked in every ear that I could. I wanted to know what everybody's tympanic membrane looked like, so that I'd be able to determine if somebody had an ear infection or not. So getting to know those normals and doing it as often as you can. And when assessing a body area, many systems may be assessed and involved. So let's say I'm doing an abdominal assessment, and I'm not only assessing the stomach and the bowel and let's say the liver and spleen and the other things going around in it. There's also arteries to be assessing. You can also be stimulating the abdominal reflexes, assessing for nerves, looking at the skin, looking for perfusion of the skin, looking for rashes, those kinds of things. There's lots of systems within one area that you can be assessing for. So IPPA, I'm just going to double check and see if we've had any questions that have popped up along that. So far, so good? Okay. So IPPA, this is the format that most hospitals, practitioners will use in terms of describing and the order. So if somebody says, you know, describe to me the IPPA of this, of your assessment. So then you're describing inspection or observation, what you found in percussion, palpation, and auscultation. And as I put there, the abdomen is the exception for that, and I'll address that. So in that checklist that I gave you, if you're wanting to practice going through a physical exam, you're always going to start with inspection. So if I'm starting, I'm going to do, let's say, a head-to-toe assessment of a patient here. So I'm going to start first by inspecting the face. So again, I'm going to be inspecting a number of things all in one system. So I'm going to be looking at the symmetry of the face, the structures of the face. Are they symmetrical? Are they, do we have one eye that's lower than the other, etc., giving us some indication of maybe some congenital issues? Are we looking for or identifying any swelling, any abrasions, any lesions on the skin? Do we have any drainage from the eyes, the nose, the mouth? All of that is within observation. Then we can get down to more focused on a system or a point. So I've done a general observation of the face. I may now get down closer and do an observation of the eye. So looking at the eyebrow, looking for any scaling of the skin, any missing hair patterns. I'm going to look at around the eyelid. Do I have any swelling, any redness, any scaling of the skin? Are the eyelashes pointing in the right directions they should be, or are they off to the side or clumped or indicating some swelling or some aversion there? Then I'm going to look a little closer at the eye, and I'm going to look inside the eye. I'll be looking at the membrane inside the eye. Is it nice and pink? Is there any discharge? Is there any swelling? Then also looking at the eyeball itself, looking at the conjunctiva. Is it nice and white? Looking at the pupil. Then you can get even to the next step if you're working through the whole system, and then that's when I would look to see shining the light in the eye and seeing the response of the pupil, and maybe even doing a Snellen eye chart and assessing for their visual fields. So in that, I've started with inspection of the total face and then focused in on the eye. We'll do the same thing, let's say, of the chest. If I'm going to do a chest assessment, I'm first going to look at the person's chest. So looking at the structures of the chest. So is the chest symmetrical? Is it round? Is the AP diameter the ratio that I'm wanting, or are they perfectly round? Instead of having more of the oval shaped, are they round and barrel chested? Will I see any cyanosis or any discoloring of the skin? Will I see any lesions? Anything that's concerning? Any masses? From there, we go then to the next step. So I've done my observation of the skin. In that, it may also include an observation of the respirations. So are they having any difficulty breathing? What is the respiratory rate? Do I see any indrawing anywhere? Do I see any tracheal tug, etc., indicating some difficulty breathing? So all of that is observation. So a lot of information that you can gather merely by observation. Then the next step, if I'm going to go percussing. It's important when going into each of these steps, we again align the physical anatomy with it. So I think I'm skipping ahead. If you want to just go to the next slide, I think I've given a little bit more. Okay, so I was running ahead of myself there. Sorry about that. So with percussion, there's a lot of things that we can be assessing for with that. So we may be assessing for the borders of an organ. So if I want to be able to determine the size of the liver, that's when I'm going to come in and I'm going to percuss. I'm going to hear different sounds and being able to identify, oh, I've gone from a tympanic sound to more of a dull sound. That must be the border of the liver here. I'm going to do the same thing coming down. I'll hear the sound change. That may be the top border of the liver. I'm going to mark and be able to measure it. So we can determine the size of organs through percussing. We can also assess for air or fluid or solid areas. So if I'm going to percuss the abdomen, I'm probably going to be able to tell. So you just had lunch, your stomach sounds a bit full, you've got a little bit of a gas accumulating in the lower intestine, you're going to get more of a tympanic sound. You haven't had a bowel movement in a few days, we may be finding some more dullness in the lower quadrant. So that's all just with percussing. So now there's two different types of percussing. So one is a direct tapping and one is an indirect. And if you go to the next slide, I've got the picture. So when we're assessing, somebody comes into the clinic to me and they're saying, I've got this pressure in my face, I think I've got a sinus infection. So direct percussion would be tapping directly on the sinuses and seeing if I'm producing any pain. The indirect percussing is what we do more often when it comes to the torso or the organs. So if I'm going to be percussing the chest, I'm wanting to place my finger in between the ribs. If I'm putting my fingers over top of the bone, I'm going to get a dull sound. And then I can't quite tell, am I percussing and getting the sound that there's fluid in the lung? Or am I getting bone? So you want to be making sure that you're putting your finger in between the ribs so that you're getting that proper sound. You can practice. I don't know if you probably can't hear it from there, but in that picture on the bottom, using your finger to tap, and you should be able to hear a good loud sound when you're doing your percussing. So again, the majority of the time is going to be the indirect. You may do some direct percussing on some of the more solid structures like the face. And next, so palpation. There's different things that you're going to be palpating when it comes to this aspect. So if I'm doing a chest assessment, I may palpate the chest looking for any tenderness. So if somebody's been coughing a lot, you've got a really bad cold and you've had lots of coughing, we want to determine, is the chest pain you're having from more of a cardiac source, respiratory source, an abdominal source, or perhaps a musculoskeletal. So I may do some palpating along the ribs to see if I can reproduce that pain and determine if it's maybe more of a musculoskeletal pain that you're having. You may also do some palpating if I'm wanting to determine that liver border. So in this individual, you can see our nice massive liver here, but you'll see that it mostly is underneath your ribs. So you're having to really palpate deep in order to feel the edge of the liver. And most of the time, you shouldn't be feeling that edge in adults. In children, it's different. We also palpate for pulses. So in the bottom left corner there, you'll see he's palpating a pulse in the hand. We've got the other areas where you palpate groin pulses, radial, brachial, carotid, etc. So feeling for that blood flow with your fingers. Again, assessing for something different than if I'm palpating for pain. So I don't have a need to exemplify here, so I've got the picture there. So you may also palpate for fluid, or you may palpate for movement. So we can be looking at a knee and seeing the movement of the kneecap, but we can also assess and palpate for some fluid in the joint. Palpating organs such as the thyroid, feeling for any nodules or tenderness. Again, another form of palpating, looking for different things. Next slide. So auscultation. Where did I put my stethoscope here? So I've got my stethoscope and I'm going to listen to my patient. So I've got the picture there for the diagram of the chest. So again, correlating what I'm going to be listening to what the anatomy is underneath. So what lobe of the lung am I listening to? Am I getting right down low to be able to hear that lower lobe? And what am I hearing within those lobes? Remembering that the right side of the chest is different from the left side of the chest because of the area that the heart takes up. We can also palpate, let's say for a brewery, carotid, you may hear brewery sometimes in the temporal arteries. And then when you're auscultating the stomach as well, you'll auscultate for those stomach sounds, but you can also auscultate for arteries and breweries and blood flow in the abdomen as well. So the abdomen is the exception when it comes to following the IPPA format. For the abdomen, I'm going to inspect and then I'm going to auscultate. The reason for that is that if I'm getting in there and I'm pushing around at the abdomen and auscultating last, I may be producing all sorts of sounds and noises and things going on inside of there that I wouldn't have heard otherwise. And it may mask some of the other things that I need to be hearing. So I'm going to auscultate first, then I'm going to percuss. I'm percussing both for the different sounds to be hearing if I'm getting dullness or tympany, but I'm also in that percussing of the abdomen, you're seeing if you're producing any pain. And then you're going to palpate very last. And the abdomen is where you're going to do some light palpation first, and then you're going deep palpation last. And always remembering to start in the area where there's least pain, if somebody's having abdominal pain, and going to that area of abdominal pain last. Again, starting least pain to most pain when you're palpating. I think we've come. Okay, so that was the end of kind of more of the formal slide part. Do we have any questions that have come up?
There's none so far.
None so far? Okay. So feel free, if you do have questions, type them in and then we'll do some Q&A at the end. So I gave a couple of the, some little tools that you can use. So the head to toe assessment, I've included the YouTube link for videos. So Bates is a good resource. There's also, excuse me as I step out, Jarvis is another text that we often use in the Faculty of Nursing, or College of Nursing now, they've changed the name, is the Jarvis text has a Canadian version. So you've got all your normals and all your information in the Canadian format, which is nice. So I gave these to you so that you would have a little bit of an outline that if you're wanting to follow. So this checklist is if you want to practice or if you want to get into a flow of how you would do a head-to-toe assessment. If you're either being tested on it or if you're working in an environment, let's say pre-op clinic where you're doing more of an comprehensive assessment. What are we doing for time?
Yeah.
Good? Okay.
Half an hour left.
Perfect. So with the assessment is we always have history attached with it. And I'm not going into a big part of history because that's a whole nother class in itself. But it's important to keep the communication open when you're going through your physical exam. So I already mentioned using language, making sure that the patient's understanding you, those kinds of things. It's also important to explain the purpose of what you're about to do. So if you're coming in and you're going to do your exam on a patient and you're not prefacing it as to the purpose of it, why I'm doing this, it's also a little bit more challenging to get a patient, let's say, on board with being cooperative. So the more you can do to prepare their patient and have them have an understanding of what we're doing and why we're doing it, the better we are with being able to work together as a team between practitioner and patient. So I would introduce myself to my patient. Hi, my name is Cheryl Dika. I'm a nurse practitioner, and I'm going to proceed with doing a head-to-toe assessment as part of our pre-op clinic today. I would ask them for their name, and a part of good communication is ensuring that you're using their name as well. If you use somebody's personal name throughout an encounter a couple of times, it shows that you've paid attention to who they are, and it also creates a bit of a relationship and a connection between you and your patient, showing them that they're important to you. What shall we name our individual here? Any suggestions? Peter. Peter? Okay, so this is Peter. He's come here to help us today. So Peter, we're going to go ahead with the assessment if you're okay with that. Are you comfortable with the way you're sitting at the moment? We're missing a few organs, so we'll work with what we have. Peter's in pretty rough shape today. So I'm going to ensure that I have a blanket. I'm going to cover Peter as appropriate for the exam and only be exposing what I'm going to be going and needing to expose as I'm doing it, and always giving him warning before I'm removing the blanket. I'm ensuring I've got all my equipment here in front of me on my table. I'm ready to go. You can use the assessment as a teaching tool as you go through it. So let's say Peter is coming in for a lobectomy. He's already missing half his lung. So Peter is here for his pre-op appointment for his lobectomy. Let's say he's been a smoker for years. We may use this as an opportunity to talk a little bit about what smoking, although he may be fully aware of it, what smoking does, or some of the implications of continuing to smoke in the post-op phase in terms of healing, etc. It's also a time when you can engage with the patient about their body. So a lot of people don't know, let's say that your liver is a large organ and you can't normally palpate it or normally be able to feel it. Or let's say that your carotid arteries are so large and that they actually go all the way up into your brain as opposed to just being here in your neck, things like that. Giving little information tidbits as you go can be educational for the patient. So everything I'm going to do when I'm touching my patient is going to be deliberate and gentle. I'm going to try not to do really jerky motions or be too harsh or too gentle. So it can sometimes take a bit of a fine line. If we're really, really gentle, one, it can show that we're maybe timid or not as secure with what we're about to do. But it can also be a bit ticklish for patients, or not as comfortable as if we're having more of a firm, secure touch with our patients. So I'm going to be confident in my touch with Peter. I'm going to engage with him as we go through things. So point number 6 is begin and end exam with hand washing. So as we all know, as soon as we enter an encounter with a patient, we should be washing our hands. And then when we're done the physical exam, we should be washing our hands. Throughout the exam, we should be wearing gloves as appropriate as well, anytime that we're going to be running into any body fluids. And you may find that you create your own systematic process for doing a head-to-toe assessment. Like I said, you may find it easiest if you go from head all the way to toe, or if you're doing things in terms of system. You need to figure out what works well for you, but also consider for your patient that you're not making them stand up, sit down, lie down, stand up, sit down, lie down, walk across the room, sit down, stand up, and throughout the process. You may have increased heart rate and shortness of breath throughout by the time you get to the end. So we're always starting off with our blood pressure, our vital signs, those kinds of things when we first meet a patient, generally. So skin, I mentioned before, inspection can be a full system, or you can do it as you work through the systems. I'm going to go through the checklist in kind of a general format. I'm not going to go through each little step of how you do things because we don't quite have the time for that. I described a little bit before and how I would be inspecting the head and the facial features. You can do head and neck all in one system. Lymph nodes is an important thing to be able to assess. And I often encourage people, when you're practicing, have verbal diarrhea, so to speak, so that in your head, as you're doing it with a patient, you'll be able to run through all of these things in your head. Of course, in front of the patient, I'm not going to stand there and go, so I'm looking at your face, it's symmetrical, your left eye is slightly elevated, you've got a little bit of swelling around your left eyebrow. I'm not going to verbalize it that way in front of the patient, but for practice, it's a great way to get it ingrained in your head what you're doing with each step. So when I'm working with the lymph nodes, when I'm practicing, I'm going to name all of the lymph nodes because it's important to be able to identify when you're charting which lymph nodes they are that you've been able to palpate or are enlarged. When it comes to doing cranial nerves or doing a neuro exam, it's the order that you do it is going to be slightly determined by the purpose of your assessment. So we don't do cranial nerve checks on a regular basis. We may do it if we have any sort of neurological complaints or headaches or those kinds of things that we're concerned about. So in that regard, you can do them either with the system. So if somebody's complaining of back pain, I'm going to check the neurological pathways of their legs, but I'm not going to bother with their upper body if I'm more concerned about something that would be back related as opposed to brain related. So again, being able to correlate why I'm doing an assessment with the anatomy that's there. So if you work through, so we've got the cranial nerves, which each system, so I've tried to group them so that they're in kind of a format as to what you would be looking at in that system. When we're moving down into more of the chest and thorax, again, I did a little bit of a brief overview of what I might be looking for in the chest. You're going to do an assessment of the posterior chest as well as the anterior chest. You don't want to be just doing one side and forgetting about the other. So for cardiovascular, again, it's really tricky, and it's only if you're listening to heart sounds on a very regular basis, working in a cardiac unit, let's say, that you'll be able to really identify what murmur is, what type, and at what grade. But it's important to be able to listen to heart sounds on a regular basis, know where you're listening, be able to landmark. So landmark where you're listening for and what, so that if you do hear something abnormal, you're able to identify where you're hearing it and then be able to correlate a little bit with anatomy. So if I'm listening at this location, I am hearing, let's say, the aorta, or if I'm listening in this location, I am hearing something that's coming from the mitral valve, etc. So you may not be able to determine exactly the name or the grade of the murmur, but you're able to identify by anatomy correlated with your assessment as to where it's coming from, and that it is abnormal. Beyond that, it gets a bit tricky. Whenever you're doing the heart sounds, you want to be listening both with the bell and the diaphragm of your stethoscope. So for me, I've got a cardiac stethoscope that I use a lot of the time, except with pediatrics, because this is a very large stethoscope to be using for a little chest. If I do use this on a kid, I can hear everything from their mouth to their stomach just by placing the stethoscope in one place. So it's very hard to differentiate where the sounds are coming from in kids. So if I'm using a big stethoscope, I'm using it on an adult, I'm going to be placing it, I am listening both with the bell and the diaphragm in all of the locations. So it's up to you whether you go through with, let's say, diaphragm and then you switch to bell, or if at each site you switch back and forth. Again, some of that's personal preference. But you want to be listening. You're going to hear more of those lower, deeper sounds with your bell than you will with the diaphragm. Again, with the abdomen, you're listening with the diaphragm. You'll hear different sounds, the lower sounds with the bell. So I've added that, just a little point in the bottom. And then with that, you're checking pulses. So again, correlating any physical anatomy with what you're doing. So if I'm concerned, let's say, about somebody's blood pressure or pulse rate, I may be checking radial pulses, but I may listen to the heart and see if it's correlating, etc. Just making sure that everyone can still hear and see, etc. Feel free to write in some questions if anything's coming up. Okay, perfect, good. So I talked about percussing. When we get onto the, I think that's our last page of that checklist, it talks about percussing the 4 quadrants as well as checking organ size. Not often that you'll do this on a regular basis, but it is important that if you're working in a unit, I'm trying to think. So let's say you're working in a unit where you're assessing liver, or somebody's come in with liver damage, or you're concerned about liver size. That may be a time that you're percussing and checking for liver size, or for spleen. I'm trying to think. A teenage kid that has mono, and you're wanting to ensure that they don't have any enlarged spleen in relation to their mono or organomegaly. So there's certain instances where you'll be checking those, but it's not percussing the size of a spleen and a liver isn't something that you'll do on a regular basis on a unit or in a clinic. But I have included those just so that it's something that you're aware and able to kind of practice as you go through if you want. But it is important to be assessing the general abdomen, auscultating, palpating, percussing in the general abdomen. When it comes to musculoskeletal, there's lots of different things that you may be assessing for. So let's say we're working in an orthopedic unit, and we've got a patient that is post-op after a joint replacement. So we've got a knee that's been replaced, one knee's been replaced, and the other knee is their good knee. A lot of the time they've been compensating, and so their good knee is actually not so great either. So we're going to be assessing both for the post-operative concerns of this joint, but also taking into consideration that there's some mobility issues. They may be having some joint pain elsewhere. They may be having some back pain as well. So making sure that we're not becoming too focused or narrow on just that operative spot, and that the operation will have impacted, or them compensating prior to the operation will have impacted the rest of their body as well. So with doing a musculoskeletal assessment, sometimes you'll mix in neurological assessment with it. Like I said, if somebody's coming in with complaining of back pain, so we're trying to determine the cause of the back pain, we may be doing some neurological assessments of the legs as well as the musculoskeletal, looking at some of the causes and the effect of what's been going on for them. So when you're doing a neurological exam, again, understanding the anatomy behind it. So if I am testing this cranial nerve, what is the impact in that? So if I am checking reflexes and I've got a hyper reflex on one leg and less of a reflex on the other, how I'm going to chart that? How do I grade them? And then how do I report that are the things that you need to take into consideration when you're doing it. So it's great if we can go through the steps of a physical exam, but we also need to know how we're going to be relaying this information both in report and chart. So that's where this checklist helps to work through the process of doing the assessment, and then you need to match it up with a good textbook in terms of the techniques of the physical exam, as well as what context in anatomy that you're testing. Any questions popped up there? No. Some flashes. Okay. Any questions? I feel like I'm rambling on and on without any feedback. We have time to open up to audio if
we do. You've got 10 minutes left.
10 minutes. If not, I will keep on rambling. But I want to give the opportunity for you to ask questions, or if there's certain contexts of things you're not sure about.
I have a question for them. If this would be a common role for them to do this.
A common role?
Yeah.
So it'll be in different contexts. So every time you come onto shift in hospital, so let's say I've been using the operative scenario. If you're working on an operation post-op unit, so I'm working on a GI floor, I'm going to come onto shift and I'm going to be assessing my patients at the beginning of every shift. And then throughout the shift, using that initial assessment that I did as my benchmark. So I'll see, want to be able to look at the incision site, want to know how digestion and their eating and those kinds of things have been taking place. And then that's going to be used as my benchmark later on in the day. So that I can come back and look at the incision site again, checking for any swelling, any bleeding, determining pain, seeing how they're tolerating foods, fluids, you know, elimination, poops and poops, pees and poops, and those kinds of things throughout the day as well. So that's going to be different. Let's say I'm working on a medical unit and I have patients that have multiple issues. So let's say Peter here is on the medical floor and he has a history of he's had a heart attack, he has diabetes, those kinds of things, and he's now in hospital because he's had some congestive heart failure. When I come onto my shift, I'm going to be doing my general survey of him, seeing his skin color, those kinds of things. How is he perfusing? I'm going to be taking note of his breathing. Is he short of breath? Has he been having any chest pain? Then I'm going to be assessing his chest. I'm going to be listening to his heart, see how his heart is coping, listening to his lungs, determining if I'm hearing any fluid in his lungs as backup, etc. And then checking his blood sugars or anything as well that is his other comorbidities or other issues. So that I would do at the beginning of every shift and then continue to monitor throughout the shift. So depending on how acute the unit is that you're working on, you may be doing vitals only once a shift or doing your assessment once a shift. If you're working on more of an acute unit, you may be doing it every hour or every 2 hours. So it'll determine a little bit about by where you're working. IPPA, the physical examination with 4 key steps. So yeah, so IPPA, so the I is inspection, P is percussion, palpation, and auscultation, yeah. Meaning if wound is because of diabetes, we will assess for other complications. So yes, so if you have a patient who is diabetic, they may have a wound or they may be coming in with a wound. So there's the larger context. So you'll be checking blood sugars. You'll be checking to see if they have any other wounds related to diabetes, so foot care, perfusion. They may have perfusion issues into their legs, so checking their pulses, checking the warmth of their legs, those kinds of things would go with it. If an exam, we are asked for focused assessment for chest pain or wound assessment, then we will just do assessment for that diagnosis or anything else. So correct. So that would be a focused assessment where you're focusing on what that complaint is. So like I said, it's not very often that you will do a full head to toe assessment. Most of the time you will be focusing on that area in relation to what you're working on. So again, if you have a patient that does have a wound and is diabetic or has high blood pressure or let's say has MS, it may have nothing to do with what their wound is, that they're in hospital for that wound, but all of those things are going to impact the patient and impact your assessment. So that may impact in terms of mobility, etc., or it may cause them to have other pains which you would be assessing for. So yeah, so your experience in terms of physical exam may be different depending on where you're coming from as well. So your role may be different. So yeah, interested to see how that would be for others.
There's 5 minutes left. 5 minutes?
Okay. So anyone else with questions? But just, yeah, as a recap. So if I am, let's say I'm working in the emergency department. There, I'm going to do a full survey of my patient when I walk in. I'm going to want to be ensuring that my environment is safe and I've got the equipment that I need. And there you may be doing more of a full assessment because you don't know the impact of what has happened before coming in to emerge. Whereas on the ward, if you're working in hospital in the ward, there's a little bit more of a control of the environment. you have to change your approach or your assessment depending on what has happened. So I may have a patient, let's say, that has come in with, so Peter came in with his heart failure, but he fell at night. So I'm coming in as the day shift. I'm going to do my assessment of his heart and his lungs and his perfusion and his breathing, that kind of thing. But I'm also going to be concerned now about this fall. So I may be doing an assessment of his hip. I may be looking for any swelling or bruising. I may be looking for any lacerations of the area, but then I may also be seeing how he can move the leg. Is he having pain that radiates down the leg? Is he able to move the hip, move his back, move his knee? Was there any other injuries? So my assessment that morning is going to change depending on, let's say, the context of what happened the shift before me. So to summarize, do a full survey, ensure environment is safe, and then change approach and assessment depending on what happened. So absolutely. The other thing to also consider is that when, let's say, a patient is in hospital for a long period of time, their environment has drastically changed. So their sleeping habits have probably changed, their eating habits have changed, and their supports around them have changed. So that creates a real psychological impact as well for mental health. Any of us are a little bit maybe more on edge, a little bit harder to heal and to become more of ourselves if we haven't had a good night's sleep. So taking that into perspective as well when we're working with patients that have been in hospital for a while, maybe a little bit of sleep deprivation and being cognizant of that when we go in to do our assessments. How urgent is our assessment? Can we let them sleep a little bit if they finally fallen asleep? What is the context of them being there? Sleep is a very important thing, and having those supports or times with family is also important, but we also need to do our job. So making sure that we've got a balance between all of these things within the context of the hospital. No questions?
No, quite much.
I'm not used to this. Everybody out there?
Yeah, we've had over 30 people.
Wow, excellent. So when I was in nursing school, I have a classmate whose organs are inverted. That might make the assessment difficult. Absolutely. So there's all sorts of conditions that will make a difference in your assessment. I had a patient that had come in. She had a birth defect where actually all of her organs were in her chest cavity. So if you were doing an abdominal assessment, there were no organs in this area. Her chest cavity came down a little bit lower, but we were listening to her bowel sounds and everything within her chest cavity. So knowing that absolutely there is no absolutes when it comes to the physical body. So there are norms that we expect, but there are also things that we have to consider outside of that. Yeah, thank you for that. It's important. In India, nurses, as a routine, don't do assessments. They do observations, but doctors are entitled to take decisions and do assessments. So then this is a very different role if you're coming here as a nurse, and especially, let's say, on a night shift, you're the one doing the assessment, calling the physician and saying, so I've seen the change in this incision, or the patient is in more pain, and I found this on assessment. So it puts more responsibility on you because you are relaying to the physician what your physical findings are, what your assessment is of the patient, and then the physician is then making decisions based on your assessment. So that's where it's really key to be able to correlate the anatomy with your physical assessment, but also be able to report it and be able to verbalize or be able to write it down exactly what you have found in your assessment, and to be able to do that appropriately so that you are providing the right information for them to be making their decisions on. Any other questions, comments?
In the Philippines.
How about, is there anybody there? What would your role be as a nurse in the Philippines? Now, there may be some variations as well from hospital to hospital. In the Philippines, you do the same thing. Okay, yeah. As a nurse, I always wanted to do assessment. So now this is your opportunity. So a great way is using the checklist that I provided you, having a textbook, and then practicing on family, friends, anyone that you can pin down to be able to work through those. We do a primary assessment and then refer to a doctor, and they will do the complete assessment. Victory place of practice, absolutely. Any others? There is also some physical assessment text that you can access online. So if you Google Jarvis or Bates, you can get portions of the textbook online as well. And then there's lots of videos, lots of Bates videos, which are good for doing the assessment on YouTube.
Okay, if there's no more questions, we'll turn on everyone's audio to say thank you for this.
Okay.
It's very informative.
We're going to turn on your audio,
Participants.
and we'll do.
Okay.
Cheryl.
Hi, everyone. So I just want to say thank you to Cheryl.
Thank you.
Thank you.
Thank you, Cheryl.
Bye.
Bye. Thank you.